دكتور نشوان are you online؟
السلام عليكم ورحمة الله وبركاته.
مصطفى شوف نشوان
موجود أنا. تسمعوني؟
we will start in the third topics or the fourth اللي هو where is دكتور نشوان fourth.
تسمعوني؟ السلام عليكم. أنا موجود. تسمعوني؟
tools and techniques below the intervention. دكتور نشوان العطاب consultant vascular surgery is online from the Arab Emirates.
السلام عليكم ورحمة الله. تسمعوني؟ الصوت واضح؟ السلام عليكم. السلام عليكم. الو السلام عليكم.
ماذا قال له؟
السلام عليكم.
مصطفى something wrong.
السلام عليكم. السلام عليكم. تسمعوني؟
نشوان ما عمل الشيء خلاص.
السلام عليكم. السلام عليكم.
نشوان are you hearing me؟
الصوت واضح ولا لا؟ I can hear you, but do you hear me? I can hear you well. السلام عليكم. السلام عليكم. ايوه اسمعكم.
Floor for you. You can start. يلا.
بسم الله الرحمن الرحيم. Tools and techniques below the knee interventions. الأمور واضحة ولا لا؟ الصوت واضح؟
واضح. الصوت والسلايد in the monitor. Start.
بس ما أنا عارف ال problem with the yes. So introduction, incidence of infrapopliteal disease among patients with critical limb ischemia, particularly in diabetic patients, is more than 70%. Before the starting PTK interventions, we should consider the treatment of critical limb ischemia and the goal of ensuring wound healing to avoid amputation, decreasing wrist pain, increasing mobilization of patient, and finally improving the survival. Class 1 recommendation. Clinical feature of infrapopliteal lesions in chronic limb ischemia, critical limb ischemia, long and diffuse lesion, calcified, totally occluded lesions. This features makes it extremely challenging to achieve optimal initial procedural success and long-term durability. Revascularization of below ankle arteries requires even further skill sets, understanding of the anatomy of arch, wire escalation, and careful approach to prevent damage to the pedal arteries. Next, sorry, techniques. The strategy of targeting these vessels that supply the greatest quantities of blood to the wound sites is very important in endovascular therapy. Angiosomes. These strategies would potentially shorten time to wound healing and should therefore be attempted. And this is the diagram showed the summary of the angiosomes. What does it mean, angiosomes? So the red shows the dorsum of the foot, which supplied by dorsalis pedis artery. Lateral ankle, which is orange, supplied by lateral calcaneal artery, which comes from the posterior artery. Plantar heel, which is green, the green color you could see in the picture, which shows lateral calcaneal supplied by lateral calcaneal artery, also by posterior tibial artery. Medial ankle, which is a light blue, supplied by calcaneal branch, comes from posterior tibial artery. Medial instep blue, which is supplied by medial plantar artery, posterior tibial artery. Lateral plantar forefoot, yellow. Lateral, also supplied by lateral plantar artery, posterior tibial artery. So angiostomes is very important in endovascular therapy to ensure to expedite the process of healing. So if, for example, if you have an heel ulcer, you have to focus on revascularization of the posterior tibial artery, and the other way, if you have a blackish discoloration of the toes or non-healed ulceration of the big toe, then you have to focus on the territory of the dorsalis pedis artery, how to increase the blood flow. This is different from when you do a bypass. Bypass, you don't need to focus in angiostomes because the amount of blood flow to the foot is much higher than in endovascular therapy. So what are factors that affect the success of the endovascular therapy for below knee tibial arteries? So whether the lesion is stenosis or occlusion, the lesion length, whether it's more than 15, less than 15 centimeters, tortuosity of the lesion, presence and distribution of vessel calcifications. So the severity of these factors should be considered prior to selection of appropriate wire. Technical strategy are adopted based on each of the previously mentioned factors. So the selection and tracking of target vessels is attempted with a curve set at a point that is 2 to 3 millimeters from the tip of hydrophilic guide wire. Example, Gladius Asahi, advantage glide wire 14, followed by 2 by 120 millimeter regular balloon at 12 ATM for 3 minutes. So what does it mean? If you have just an severe stenosis with angled ostium, so you have the best option to use is a starting wire, which is hydrophilic wire. Tip load is less than 4 grams. So you have to understand the technology of wires, because not each wire can fit all lesions. So only every lesion has its own preference and character. So in case of we have only stenosis, we have just you can use any wire with small tip load less than 4 grams. And usually the examples of these wires is Gladius, Asahi. This is Asahi, one company produce 3 types of wires. One of them is Gladius. Second one is Hilbert, which has tip load 12. And there is Tattoo also, which tip load is 40. This 40 is only for chronic, totally occluded, calcified vessels. So in just stenosis, you can use Asahi, you can use Advantage glide wire, you can use Netrix from Medtronic, any simple wires. So if you have a short occlusions, you can see the pictures, short occlusion with no or mild calcification. If there is no calcification, it's only short occlusion, then Asahi Gladius wire 014, pre-shaped advanced with microcatheter. Pre-shaped means you can just shape it by the needle. Advanced with microcatheter, which is supportive catheter, in antegrade fashion. That means it comes from the common femoral artery. So you could cross easily this, and followed by dilatation of the lesion by 2 by 40 short balloon. You always consider in doing angioplasty of the tibial vessels, you have to inflate the balloon at least 3 minutes to avoid retreat or severe calcification. Now you have to use C2O wires. C2O wires is produced by Koch company. It has a stiff tip, and also you could use another wire, which is my experience is Hilbert wire from the Asahi, as we discussed previously, which has a tip load 18. But the problem with the C2O, as mentioned, that perforation is high because of the tip load is high. So a tip injection from microcatheter revealed a hairline at the C2O side. So before you attempt to cross a heavy calcified short lesion, you do angiogram using a microcatheter, and then to show this micro channel. So to minimize the risk of perforation. So an example also Asahi, as we mentioned, Hilbert tip load, a Hilbert wire with a tip load is, as we said, 18, is advanced with microcatheter, followed by 3 by 300 millimeter balloon at 8 ATM for 3 minutes. So this is for a long lesion. You could use a 3 millimeter balloon. So if you have a long occlusion without calcification, it's difficult to maintain intraluminal. If you have long occlusion, example, posterior tibial completely occluded, anterior tibial completely occluded, so it's difficult to maintain intraluminal tracking. So you go for subintimal, what you call it. It is so that it's better to cross the lesion using loop wire technique, as shown in this picture. You could see here. We call this in the knuckle wire technique with bidirectional approach. What does it mean bidirectional? If you have sometimes you could go from pedal also. So what wires fits for this kind of lesion? I prefer always command wire, which is glide wire, accompanied by 4.2 French CXI catheter from Koch, then 3 by 300 millimeter regular balloon at 8 ATM for 3 minutes. So I give you example cases of my cases that I have done myself. So this is 158-year-old male patient, diabetes, hypertensive, smoker, Rutherford 5, wrist pain, 2 gangrene. You could see the angiogram.
And posterior tibial artery with multiple stenosis of the peroneal artery. Angioplasty done, and this is the result.
This patient has a calcification with a long occlusion. You could see
results in the foot.
You could see the full arch of the when you open 2 or 3, there is a large studies regarding this. There is no if you just open one artery per angiosome, it is enough to heal the ulcer. But if you open 3, that more blood to the foot, so expedite the process of healing. So total occlusion with calcification. Now an example of total occlusion with calcification. So the whole artery is calcified and totally occluded from the origin to the foot. So this is the most challenging case. So CTO wire you have to use, or heavy wire, as we said, with the tip load of 18 gram. But as mentioned, the side effect of this perforation dissection. So intentionally subintimal, you have to go for subintimal tracking using bidirectional knuckle wire technique with 0.35-inch wire. Be considered for recanalization, accompanied by, as we said, 4 French CXI catheter. CXI catheter was one of the best catheter used in such scenario. And we have also another catheters, Seeker, also another or short cross from Merit, and Seeker from BD, from BART. A knuckle wire technique using 0.35-inch 1.5 millimeter G-tip wire, accompanied by 4.2 CXI catheter in retrograde fashion. So in case you cannot go from antegrade, we go from retrograde using CXI catheter and using 0.35. Example of the long occlusion. 67-year-old male with the multiple comorbidities, ischemic heart disease, ejection fraction 25%, come to ER with the wrist pain, minor tissue loss, Rutherford 5. Ultrasound shows normal flow and spectral waves in the common femoral artery and popliteal arteries. CT angio showed stenosis of P3 and complete occlusion of its trifurcation. So this is complete occlusion of all tibial arteries. And you could see how you could see here the popliteal, and this is all collaterals, all collaterals. There is no anterior tibial, there is no posterior tibial, no peroneal artery. All this is collateral. And so this is what I was mentioned about bidirectional. So we go from antegrade, and we tried. You could see the blood, how much trial we have used to cross. And this is a long sheet, what you call coaxial system. Putting the sheet in the popliteal artery to increase the pushability, trackability, and followed by crossing catheter. Instead of this, I couldn't cross, so I go from pedal access. You could see the sheath, micro sheath in the posterior tibial artery, and finally I could do something. It's one of the difficult case. You could see the wire going from the posterior tibial artery retrograde and following the
pedal axis. The wire is following the crossing catheter from antigate from the common femoral. See, the wire is going through the destination sheath.
And this is the destination sheath. You could use it in antegrade fashion to increase your pushability. And you could see here the angioplasty started, and this is the end result. And we completely revascularized the arch of foot. So if you have a complete arch of foot revascularization, this will increase double the and minimize shorten the period of healing of the ulcer. Thank you so much. ندري هو الو
شكرا دكتور نشوان.